Hello, I'm Antoni Chan. I'm consultant rheumatologist from the United Kingdom, reporting here at EULAR 2022 in Copenhagen. And we've had some really interesting presentations this year at EULAR. And one of the topics is around axial spondyloarthritis. For many years, we have been using anti-inflammatories, non-steroidal anti-inflammatory drugs. And the question is, does it actually retard structural change? Does it help when we use it in combination with biologics? So some really important questions in terms of clinical practice. And I'm delighted that I'm joined by Fabian Proft. He works in the charity hospital in Berlin. He's done a lot of work here at EULAR, and he's going to talk to us and share with us his insights from the CONSOL study, which was presented as an oral presentation on day one. So Fabian, welcome to today's talk. And if you could tell us a little bit about the work you've been doing, especially the CONSOL study.
Thank you, Antoni, for having me and inviting me. I'm delighted to be here with you and speak about our work that I had the honor to present, but also the work from my colleague, Murat Turgutaup. He presented in the same session, which started the EULAR on Wednesday. This was axial SPA, new and old treatments. And regarding the end states, I think we are rather speaking about the old treatments. But as you mentioned, really important, how can we retard structural changes in the spine? And as we are quite familiar, there were some data suggesting an effect for celecoxib from the WONDER study, where it was shown that the patients taking celecoxib on a regular basis, continuously every day, they had less radiographic progression than the ones taking celecoxib on demand. And this was also the starting point for our CONSOL study, that we thought, okay, what it is in the current days where we have biologics available, and what is if we are adding celecoxib to a biologic? And this was what we done in the CONSOL study. And CONSOL is a randomized controlled trial in patients with radiographic axial SPA, and especially high risk for radiographic progression. And so these were also one of the inclusion criterions. All patients needed to have either an elevated CRP level or already existing syndesmophytes at the screening. And then these were all treated with a TNF inhibitor, in this case golimumab, for 12 weeks as a run-in phase. And only these patients that were having a good clinical response, defined as a BASTA improvement at more than 2 points at week 12, were then randomized on a one-on-one basis to either the combination therapy with golimumab, and then had continuously every day 400 milligrams celecoxib added, or in the monotherapy as the control group, where they only had continuously the golimumab therapy for 2 years. And the primary endpoint was the MSAS change after 2 years of treatment to baseline. And what we saw in this cohort, in this RCT, was that there was a numerical higher radiographic progression in the monotherapy arm. This was according to the primary endpoint, the MSAS change from baseline to year 2. But this was also evident for formation of new syndesmophytes. There was a clear, and this new syndesmophytes and the agreement of all 3 readers occurred in 25% in the monotherapy arm versus only 11% in the group which were taking celecoxib continuously. So there is a numerical difference that we could detect. But this did not reach statistical significance. And therefore, we need to say the CONSOL study ended up being negative for the benefits. But when we are looking more into the data, and I really believe that either we were just not having enough power because we were only including 110 patients, the power calculation, this was also one of the questions from the audience, which was well taken. The power calculation was based on the WONDER study. And I think we need to take into account that here, the patients which were in the control group, they only had NSAIDs on demand and no background therapy. And in the CONSOL study, the control group had golimumab as a TNF inhibitor as the control, as the backup arm. And I think this might affect the changes. And therefore, we most likely would have needed a higher number to really make this numerical difference that we could observe statistical significance. So My takeaway from the study is that we have to admit that it was not significant, the add-on of celecoxib to TNF inhibitor, but it might be the numerical differences that we saw might be relevant for patients at a high risk. So if I see a patient and he's having high CRP values, he's already having structural changes in the spine, I would most likely not advise him to take celecoxib on a regular basis, but I would discuss with him to find excuses to take celecoxib. Because if you have a little bit of pain, then I would say, go for it, rather take it. If you're not feeling well on the morning and you cannot get out of bed, take it, because it might, in addition to the symptomatic effect, also have a structural change effect. And also that I will definitely have this take this into account, because we can also remember the ENRADA study where diclofenac was assessed and there was no effect. And therefore, I think my takeaways are the study ended up negative, but in patients with a high risk of structural progression, there might be a place for taking celecoxib more loosely, and also that I will prescribe the selective COX-2 inhibitors to my patients where I think the radiographic progression is something that I have to worry about, rather than the conventional unselective NSAIDs.
Yeah, that's really important key points there. I think there is, as you say, a numerical improvement, which might actually translate to a clinical improvement individually in our patients. So what is in your own clinical practice, if you know that somebody is perhaps a fast progressor, more likely to get radiographic change, and when they may have achieved some improvement on their scores with a biologic, is it your practice to keep them on the NSAIDs for longer?
Honestly speaking, no. So far, this was not my clinical routine. So I was really in these patients where I was having the feeling that there's high risk for radiographic progression. I was faster of introducing biological therapy. So if there was a patient, even if he was feeling well, but I see that the C-reactive protein was still elevated and was not improving, even though the BASDAI might be scored quite low because the patient was just, rough taking, then I was still saying, look, we know that the CRP value is a high predictor for structural changes, radiographic progression. This might give an impact on your future life. So let's have a look, maybe like make another MRI, see if there's still inflammation going on, and start a biological treatment, even though if you're not having severe back pain at the moment. But if the patient was doing perfect, was not having a CRP value, and I was still not, I was saying take the NSAIDs on demand. And I was just also from the previous data, I was having quite a tendency for the selective COX-2 inhibitors. Whereas I have to say that I was once taking them myself and was not tolerating it well. So this is something that I have to keep in mind. But still, etoricoxib and celecoxib are definitely the two NSAIDs that I'm prescribing the most in my actual SPA patients.
And is there any sort of biological explanation for the differences between COX-2 and COX-1 in your understanding in terms of radiographic change at the bone level?
There are preclinical data that could give a slight explanation. Honestly speaking, I was not strongly believing it before the ENRADA study. I was thinking that also diclo might most likely have the same effect. But yeah, there's evidence for that, and now also with this, giving us a slight explanation that it might be more effective on the bone level.
Hmm. And were there any, I mean, one of the concerns about using COX-2 inhibitors or NSAIDs are cardiovascular risks in patients, but did you see any of that coming out in the study?
There we have to be also clear and honest. I mean, we were only investigating 100 patients for a time period of 2 years. And it's important to say we had not had any. We had a pulmonary embolism, but this was in the monotherapy arm. which might most likely associated just with the disease itself. And also when we are looking back into registry data, there's also somehow in the first moment not really clear data that NSAID intake might even reduce cardiovascular risk or events. And also from my understanding, I think the most risk, the highest risk factor for cardiovascular disease is the inflammation itself. And I think if we treat the inflammation better with biologics, but also with NSAIDs, we will reduce the risk for a cardiovascular event. So I'm not so afraid of using them. Still, I mean, which is also quite clear if I have a patient having already high risk factors for cardiovascular events because of previous events or high cardiovascular risk factors, I'm more conservative with prescribing NSAIDs or selective COX-2 inhibitors. But yeah, in general, our actual SPA cohort is rather younger, is quite healthy, is not having too many comorbidities. So yeah, I'm quite confident of prescribing NSAIDs also in this cohort, also on a long-term basis.
Yeah, so actively treat the inflammation because
Absolutely.
that itself is a risk for more cardiovascular disease itself. And also one of the topics that was presented was the GASPIC study or the GASPIC cohort, which you're also very much involved in. How do you see that sort of linked to the work that you're doing?
And this is an important part of my understanding of the whole matter of NSAIDs and selective COX-2 inhibitors and actual SPA, because Murat Turgutov, he also from our department, he was presenting the 10-year data of the GASPIC cohort, focusing on radiographic spinal progression and the effect of NSAIDs, and also the differentiation between unselective and selective COX-2 inhibitors. And he showed that there was an effect of NSAID intake over the 10 years of treatment, which was more pronounced in the radiographic group of GASPIC than in the non-radiographic group, which makes sense because I think these patients are having just per se a higher risk for radiographic progression, and there you can just have a higher impact when you treat the inflammation and treat the radiographic progression better. And it was also shown that the selective COX-2 inhibitors are having a stronger effect than the unselective. So I think when just combining the observational cohort data from GASPIC together with the RCT data from CONSU, I would truly believe that there is an effect of NSAIDs in general, which is stronger pronounced from the selective COX-2 inhibitors, which is even stronger pronounced in radiographic patients and especially in those having high risk for radiographic progression. And yeah, my assumption is that most likely just the power of our CONSU study was not high enough to show this effect on a significant statistical basis.
Yes, so there might be some further research into this area going forward. And we know that in male patients, they tend to progress quicker than female patients. One of the key topics that have been coming out is the gender differences or sex differences in these patients. Your study obviously wasn't designed to kind of answer that question, but do you think in terms of a research question going forward, is that something that we would need to consider in terms of the whole topic of radiographic progression and the role of NSAIDs?
It might make sense, especially because just as you said, it is we know that male gender, HLA-B27 positivity, high disease activity, these are the main risk factors for radiographic spinal progression. And also, I mean, we had a quite typical radiographic axial SPA cohort in CONSU, but the numbers, if we would then make a subgroup analysis, the numbers are going down. But if we would select the ideal patient cohort and having only male patients with high disease activity, which are most likely to progress, and treat those and randomize those on celecoxib, I would assume that it might give a stronger hint that celecoxib is really preventing radiographic spinal progression. And so
Which
this is what
translates-
will, yeah, absolutely. And this is what I think is also one of the takeaways that I will implement in my clinical practice, because I think this is also when we are discussing it here, what can the rheumatologist, what can the actual SPA expert do differently Monday or Tuesday when he's coming back to his office, or she's coming back to her office. And this is what I think is my takeaway, my personal takeaway, that I really finding an excuse in those patients where I see high risk for radiographic spinal progression for selective COX-2 inhibitor in addition to their biologic.
Yeah, so select your patients carefully, assess their risk factors, think of treat inflammation, and in those patients, probably a slight preference for COX-2. I think were some of your key messages. Going forward in the future, staring into the future, what do you think are the key topics for us to be thinking about in terms of this whole idea of radiographic progression and the role of the treatments we have? Yeah. What would be your take on this?
Yes, I think what was also presented last year from the gastric cohort, where also Murat and Dennis Podobny could perfectly show that a longer time period of TNF inhibition was needed to see the effect on the radiographic spinal progression, which was also, for me, perfectly explaining the differences in the literature that we saw, because when we are just looking after 2 years, there might not be such a strong effect. But when we are looking on the longer data, or when the treatment was longer time ago, this made sense to me. Also from preclinical data, IL-17 inhibition seems to have even maybe even a stronger effect on radiographic spinal progression. And the SURPASS study, where exactly this question is targeted in a head-to-head design, IL-17A inhibition versus TNF inhibitor. This is, I think, the hot topic on the radiographic spinal progression, because this might even change our clinical routine if we see that one or the other mode of action is having a stronger effect on inhibiting structural changes in the spine. This would be, for me personally, a very strong argument to prioritize this mode of action in my clinical routine. And also we need to take into account that with JAK inhibitors, also here the upadacitinib data on non-radiographic were presented at the EULAR. So we have now with upadacitinib one JAK inhibitor also for radiographic and non-radiographic. That might be a treatment option. This is something where we don't have any structural progression data yet, and which will be very interesting to see here the long-term data and to see how JAK inhibition will perform when compared to the older biological treatments that are already available.
So a very important outcome in the new modes of action as we learn about these drugs. Structural or radiographic progression is going to be quite an important outcome, not just in terms of efficacy, but also understanding about the disease itself, the nature of the condition. Fabian, it's been great to talk to you. We could talk all night. You have so much interesting data you presented to us to increase our body of knowledge at EULAR, and I look forward to seeing more of your work in future meetings. So thank you very much for joining us and giving us your insights into a very important and also critical topic in the whole field of axial spondyloarthritis. So thanks for your time tonight, and we look forward to hearing more from you in the future.
Antoni, thanks for having me. It was such a pleasure to be able to see each other in person at the EULAR, and I'm really much looking forward to our next encounter. Have a good one.
Bye-bye. Thanks very much.
Bye-bye.